We'll continue our series on updates to the Kentucky State EMS protocols for 2023. As always, if these are not your protocols, if you haven't officially adopted these protocols at your service, maybe consider it, but also don't use these. Don't consider this medical advice or an order because you have to have the protocol officially adopted in order to use it, and it has to be ratified by the board and that sort of thing. So if you haven't adopted these protocols, this is just education and something to think about, but this is not a definite order. That said, let's talk about the agitated patient. So this is not an entire series, lecture on how to deal with agitated patients and what they mean and that sort of thing. We want to talk a little bit just about the protocol itself. There's about a page of interesting information at the beginning of it and things that you have to think about. You'll notice that chief among these is this big, hard to miss graphic down at the bottom that we do not transport patients prone. We shouldn't lay patients prone unless you absolutely have to for just a minute. We don't restrict their airway. You don't hobble them. You don't hogtie them. And you don't transport somebody that is prone, hogtied, or hobbled, or in any way restricting their ability to clear their airway and breathe. Because why? That's how people die. So on the back, yes, just fine. Head to bed elevated, just fine. Prone, no. We don't do it. That said, let's talk about some of the other things. Just as a note, agitation can be caused by a medical condition, especially a dangerous medical condition. Agitation itself, when you look at the definition, is a change in mental status. So we don't often think of it that way, but this is as much somebody that's somnolent as it is somebody that is, running around or something like that. You got to be thinking that they may have a dangerous medical condition. And that can be a lot of different things. It can be tox, it can be psychiatric, it can be meningitis, it can be hypoxia or hypotension. There's all sorts of things that can cause moderate to severe agitation in folks. So we always have to be looking out for that. We're going to need to do a full evaluation on these folks as soon as possible, including all your vital signs, essentially, including SpO2 and a blood glucose. Don't forget the blood glucose. You have to check a blood glucose. Don't walk away from a person. Don't let them out of your sight. Don't turn your head in an altered person until somebody's gotten a finger stick, because a lot of times that can be the problem. You're also going to look for any focal or lateralizing deficits or changes, like if one arm and one leg, say, keep twitching or something like that. Maybe this is a focal seizure. Maybe this is a stroke and the person's not actually agitated. They just can't communicate because they've got neglect on the side or something like that. We're going to look for any signs of seizures, any signs of trauma, any sign of infection, neck stiffness, fever, elevated body temperature. Patient's wife says, yeah, he was sick this whole week, and then today he just got really wild. You got to be thinking infection on that. And again, not just somebody that's necessarily a psychiatric disease. One last thing on that. It is imperative that we get as much history as we can from bystanders or from the family on the scene, if at all possible, because these people, while they may be there to give you a history initially, they may disappear and important parts of this story may go away. So the only chance to get this history might be from you, the EMS provider. So we really need that carried forward regarding this event surrounding it or medical history, because again, you bring an altered person into the emergency department or a severely agitated person into the emergency department or a person who's been restrained and has got medication for that. And that history that may be very important often goes away. One last time with feeling as well, patients never are to be transported or restricted in a prone fashion or hogtied or hobbled in any way that affects their ability to self-rescue should their airway become obstructed. And that could be vomitus, that could be spit, that could be pretty much anything. We have to take care of these patients. These are critical patients. We don't transport critical patients, generally speaking, on their stomachs. All right. We then go on to break down the agitated patient into 3 or sort of 4 different categories. The easiest one of these to kind of deal with is the mildly agitated patient. This you could call, as much as anything, the very anxious patient. Somebody that's experiencing a change from their baseline mental status that is distressing to them. It's bothersome, much like pain is a bothersome symptom. This is distressing to them, but they still have capacity to make decisions. They still understand instructions. They can still comply, all that kind of stuff. These folks, we put in here an authorization to give just a small dose of midazolam, 1 to 2 milligrams IV, because yes, this is a stressful thing, and sometimes people have anxiety or trouble dealing with the situation that they're in, and they need a little bit of medicine to help calm down and make them feel better, and that's okay. So we can treat that with a little bit of IV midazolam. Again, these are folks that still comply with what you're asking them to do. They still have capacity to make decisions, that kind of stuff. And of course, we should provide them reassurance and verbal de-escalation, as we all, are presumably going to do. But we can add on a little bit of medication to make them a little less anxious and feel a bit better, less agitated, in order to facilitate getting them treated. When we start talking about the moderate to severe agitation, there's a big differentiator here, and what we have defined this as is that this is a patient that is agitated to the extent that they are unable to comply with your requests, that they lack capacity to make medical decisions, and that you have some concern for a dangerous medical condition. So why do we put those three in there? Number one, they can't do what you tell them to do or what you ask them to do, and so they're in jeopardy that way because you're acting in their best interest, hopefully. Number two, they can't have capacity, because if they have capacity and they refuse, then you have to leave them alone. You can make a bad decision unless you're confused or altered. So if the patient has capacity to make medical decisions, then you can offer them, some medicine, as we said, in the mild side, but you're not going to classify them as severely agitated. And the third part, you have to have a dangerous medical condition or concern for a dangerous medical condition or suspicion for a dangerous medical condition, which can be a lot, almost any of these severely agitated folks. However, if you are called because the police say there's this known gentleman who has psychosis, who is always running around agitated this way, and you don't, or nobody has a concern that he is different from his baseline, and you don't have any concern for a dangerous medical condition like an injury or something like that, this doesn't apply. It's not illegal to be psychotic. You can't just come up and sedate somebody for the sake of doing it. You have to have a concern for a dangerous medical condition. We can oftentimes have concern for that dangerous medical condition because they're so altered, but not all the time. So we have to throw those three things in there. All right, a lot of talk about that. This is generally intended to be, say, the patient who is maybe intoxicated and was in a motor vehicle accident, or maybe they weren't intoxicated, maybe they just whacked their head on the windshield when they were in an MVA, and now they're altered and they're fighting you, they're bucking at the stretcher, they're trying to get away, that sort of stuff. That's sort of the prototypical patient here. Likewise, again, could be the older gentleman who has, potentially sepsis or meningitis, who is fighting you and swinging at you, trying to escape off the cot or turn it over as you try to take him into the hospital. That person would fall under these categories as well. When we see this, probably the safest thing for the patient, while we often, say the least restrictive means to keep the person safe, one of the least restrictive means, in my opinion, is going to be giving them some medication to treat their severe agitation so that you don't have to do anything more severe in terms of physical restraint or something like that. Now, many of these patients will end up with restraints, and we'll talk about that in a second. But what kind of treatment can we give to these folks? We can treat their moderate to severe agitation with one of two medicines in this protocol. One is midazolam, and presumably we may be given this IV in this case. You can give 2.5 to 5 milligrams IV every 5 minutes or so. This is relatively fast acting, and 5 milligrams IV is probably going to produce a pretty significant change in their level of agitation and probably get them where you want them. If you don't have an IV or you can't establish an IV, you can give it IM 5 to 10 milligrams, depending on how agitated the patient is. We also throw in here this drug called droperidol. Droperidol is a great drug. It has a lot of different uses. It's kind of like ketamine, really, where you can do a bunch of things with it. What we use droperidol for is often sometimes sedation, sometimes anxiolysis, sometimes abdominal pain. It's a great antiemetic. There's lots of uses for it. You may never have seen it before. This is your opportunity to kind of look at it. Our dose for droperidol for sedation is going to be 5 to 10 milligrams IM one time. Now note, this may take 15 to 30 minutes to really fully kick in. So if you think additional doses are needed, you need to contact online medical control before you give an additional dose. If you have an IV established, you can give 2.5 milligrams IV. Why might you give that instead of Versed? Well, droperidol has some benefits in that it's got a little bit of antipsychotic effect to it as well, not just the sedating stuff. So sometimes it works better in different patients than midazolam. But both are, they'll sort of work. Droperidol IM is just going to take you a while longer to get in there. Now, of note, the desired level of sedation is not patient is unconscious on the stretcher. The desired level of treatment of their agitation is to the point that their actions are no longer inhibiting you from providing emergency medical care for them. That may mean that they're still not easy people to deal with, but we just want them enough that we're able to provide the care, to get the assessment done, to start the IV, to put oxygen on them, to put a SpO2 probe on them, that sort of thing. Of course, we can't really talk about agitated patients without talking about the restraints, and these folks are where the physical restraint kind of comes in. I have a philosophy that says we don't put people in physical restraint without medication. That used to say chemical restraint, but we're not chemically restraining them. We are giving them medicine to treat their agitation. But if we need to use physical restraints for the safety of the patient and the crew, then we may need to do that. Keep in mind with this, you always have to assess their PMS distal to the restraint. You need to document that every 5 minutes. You need to assess an AVPU or a GCS, a level of consciousness, every 5 minutes. When you put somebody in restraints, this is kind of a big deal, and you need to do the least amount that you absolutely have to keep the person safe. And when you put them in restraints, they, again, become essentially a critical patient, and you have to watch them pretty closely while you're doing this, because you take away the person's ability to essentially save themselves or get away if something were to happen. Now, you have to be able to immediately remove physical restraints if something were to happen, like the ambulance were to roll over and crash. You cannot restrain somebody tied to the ambulance itself. If you're going to use some sort of, physical restraint, soft restraint, even, the 4 points or whatnot, it has to be attached to the cot that you can take out of the ambulance and not to the ambulance itself. And again, the idea is if there's a fire, the patient's got to be able to get out. Somebody's got to be able to get that patient out. Now, we make a note in here of the different sort of flavors of restraints. The soft restraints, the soft padded wrist restraints that we've all kind of seen around that may be appropriate for somebody that is essentially unable to, not pull at lines or not try to extubate themselves, but is not physically violent. And these are relatively easy to break out of if you had to. They're not meant to hold a person down. They're just there to kind of keep the person's hands from coming up to their face or to the medical device or something like that. That's what we normally talk about with soft restraints. When we talk about the more heavy restraints, this is the leather restraints. This is the locking restraints. I guess you could put handcuffs in this, although that's a really different thing. Handcuffs aren't really a restraint that we're going to talk about here, and you should not be putting them on anybody. If you are going to do it, there is a technique to it, and it's beyond the scope of this particular protocol. But remember that keeping them on a diagonal, i.e. like the left foot and the right hand restrained, if you're going to put them in heavy restraints, is usually the most effective way to kind of go about that. And you want the person to try to have to extend to escape rather than to flex, because if they flex, they can oftentimes break out of those things. But extension is a lot weaker in folks, so you try to keep them trying to extend. But again, a bigger topic for another time. If you use 4-point restraints, you have to give this person medicine, because they will oftentimes continue to fight, and that's dangerous for the person. So you have to treat their agitation. And if you place a locking restraint on somebody, you have to have the key with you by the patient's side, and you cannot leave that patient's side. That includes anybody that is under law enforcement custody. If they handcuff somebody to a stretcher, then you have to have the handcuff key traveling with the patient. And in most cases, I don't think the cops are going to be real interested in giving you the handcuff key. So if you have a patient handcuffed to a stretcher, that handcuff key has to accompany the patient at all times. It has to be within, the eyesight of the patient. It's not okay if it's following along in a sheriff's car, 3 cars back down the highway, something like that. It has to be available because you don't know what kind of medical emergency may require you to have that hand free or something like that. EMS does not provide restraint for law enforcement activities. We provide restraint to keep the patient from harming themselves or us. But if the patient is being arrested, our job is not to tie this person down. That's the job of the police, and we don't get involved with that. We're not trained to do that stuff. And even if you say, well, I'm cross-trained to police, not here, you're not. Under the scope of this protocol, we do not provide restraint for law enforcement activities. We can still treat patients with severe agitation, but we do not sedate patients to facilitate arrest, and you have to keep that in mind. The last category that we'll look at is the folks that are severely and dangerously agitated. So this is patients that are not only unable to comply with the requests as the severely agitated people are that we just mentioned before. The kicker here is that this person is acting dangerously to themselves and to the crew. Not just that they aren't letting you, facilitate an exam or something like that, but they are physically dangerous to you in terms of what they're doing. These folks are critically ill. They have a high chance that they're going to end up in the ICU or get intubated or die. And so we have to treat these people as being physically ill. Now, the treatment paradigm in this is not so much give them a little bit of medicine so that they calm down to facilitate the care of them. I mean, it sort of is that, but it's really two things. One, you have to rapidly gain control of them physically for long enough to give them a rapid-acting medication in the fastest way possible. Because the faster you get this person down, the faster you can get monitors on them, the faster you can attend to their critical illness, and the less chance they have to harm themselves or harm you in the process. So if we're physically restraining these folks, we are just restraining them long enough to administer medication. Now, don't let go of them at that point, but that's the goal, is not to hold them down and make that our plan. The goal is to hold them down enough that we can poke them with a large bore needle and give them some midazolam or ketamine. Once the patient is adequately controlled pharmacologically, then you can put them in restraint still. You, again, are never going to transport these people or held for a significant length of time in a prone position or hogtied or face down in some way that doesn't allow them to adequately clear their airway if needed, or for you to access that airway if you absolutely have to. How are we going to medically treat these folks? Again, how they get taken down is oftentimes the purview of law enforcement. But how are we going to provide them medication? We're going to give, again, a big dose, and this is designed to be a big dose of a highly sedating medicine so that they calm down and stop hurting themselves and mostly get sedated and kind of go to sleep. What are we going to do that with? Well, we've got two options on here. The tried and true that is one of my favorite medications is 10 milligrams of IM midazolam. You can reduce that to a half dose if the patient's under 40 kilograms, which is a pretty small person. That's like a 10, 12-year-old child, something like that, becomes about 40 kilograms. And you can do that again in 10 minutes. The average onset to midazolam effectively sedating these folks is maybe variable. It's pretty well absorbed. I usually see effects somewhere between 5 and 10 minutes. If you have an IV established for some reason, and you're not going to take time to establish an IV, but if it was already established, you could give them 5 milligrams of IV midazolam. And again, this will probably work. I've seen very few people who I could not give 10 milligrams of midazolam for that weren't adequately controlled in under 10 minutes, and I really think closer to 5 anecdotally. Now, if you look at some of the more recent data that's out there, some of the other studies, and we can debate those studies, but they advocate using ketamine because it seems to be maybe a little bit faster. Time to onset for sedation, somewhere around 5 minutes. And again, my experience has been that ketamine doesn't quite move that fast, but it's probably pretty good either way, which is why we put both of them in there. The dose of ketamine, again, we're going to give this IM because presumably the patient is too agitated to have been able to establish an IV. You're going to give 4 to 6 milligrams per kilogram IM of adjusted ideal body weight. So your ideal body weight is based on your height, and you can approximate it at, height in centimeters minus 100 gives you your ideal body weight in kilograms, thereabouts. And then we add adjusted to it because that usually shortchanges folks, and we'll add 10 kilos just for the sake of it. what that gives you in terms of dosing is a range somewhere from 300 milligrams to 450 milligrams in an adult. And yes, you're not always going to know the weight. You're not always going to know the height. And in many cases, you probably won't. So the good thing to remember about ketamine is that it is fairly safe even over a wide dosage range. So if you were to give a small adult 400 milligrams or even 450 milligrams instead of 350, there's every chance in the world that everything is going to be just fine. But you do have to treat the side effects of the ketamine if that were to come out. The real reason that folks have had trouble with ketamine is because they fail to treat the patient as critically ill after they've given them the medicine. They take the benefit that the patient is now sedated and they totally forget that this patient is still critically ill. So a wide dosing range is actually okay because we're going to be approximating this stuff anyway. And again, it's a safe drug to use in that way. One of the interesting things about ketamine, in fact, is that once you get dissociated, more ketamine doesn't make you more dissociated. It often just kind of lasts longer. So even a heftier dose doesn't necessarily produce more of an effect per se. Again, if you did have an IV, there's an IV dose in there, but it's pretty unlikely you'd have an IV for this. When you're giving these IM medications, you're going to give it through a large needle into the thigh or into essentially the muscular part of the buttock. You might just have to go through clothing if the patient or provider safety is in question. You don't necessarily have to go through skin, and if you wipe it down with alcohol first, that's more than sufficient for these folks because, again, chance of infection relatively low. Chance that they're going to hurt themselves or others, which is why we're doing all this, is pretty high. Most of these drugs work in 5 to 10 minutes if you've given an adequate dose. The adequate dose is important. You don't want to underdose. An adequate dose will work in about 5 to 10 minutes. As soon as at all possible, you have to put a cardiac monitor, an SpO2 probe, an end-tidal CO2 probe, and obtain a BP on all these folks, as well as check a finger stick. Don't forget that. And by the way, what does as soon as possible mean? It doesn't mean when the person's fully sedated. It doesn't mean when the person's loaded into the ambulance. It means when they have calmed enough that you are able to access their finger, you should put an SpO2 probe on it. That doesn't take them being very calm to do. Likewise, you don't have to have the patient turned over, restrained to the cot and have everything done in order to put a cardiac monitor on them. And in fact, if you're doing that, you're waiting far too long. What can you do? You could cut open the back of the patient's shirt if they're on the ground and again, they're held down, which is the common case. You can cut open their shirt, apply your EKG leads to the shoulders and to the sides of the back, and that will give you, some cardiac monitoring. Maybe it's not exactly what you were seeing on, front leads, but it'll work. It'll be okay. It'll give you an idea. It will certainly tell you if the guy goes into VF or VT. Likewise, you could just slap a pair of pads on them and go that way. That will also work. We have to get some monitoring on these folks as soon as possible because the most dangerous time is after we give them medicine, they start to seem to calm down a little bit and then they stop talking. Are they not talking because they are dead, or are they not talking because they're adequately sedated? You don't have a way of knowing that till we get monitors and leads on these folks, so you have to do that. As always, be prepared to manage the airway with the use of any kind of sedation. Once you get these people attached to the cot and sort of knock down a little bit and get the fight out of them, raise the head of bed up. If you want to keep them in a lateral trauma position or something like that, that's fine. But at least raise their head of bed up to 30 degrees so that if they do vomit, it doesn't go right down their trachea. Do something to be able to manage their airway, and a little bit of head of bed elevation is good for that. Couple more notes for you. It is okay to go ahead and give these folks a liter of crystalloid. That's, in this case, probably not going to hurt anything. If you have sedated a patient, when you do that, you cannot leave them. You cannot walk away. You can't walk someplace else. You can't leave them sitting up next to a squad car. You can't leave them just in the hands of the police. You have to stay with this person until you hand them over to the hospital. You are married to that person. You are bound at the hip once you give them this medication. You cannot leave them. Somebody else has to take care of other sort of tasks if need be. Remember that some side effects of ketamine include nausea and vomiting, which we can deal with if we have the patient turned over on their back, and again, maybe or maybe on their side. Hypersalivation, which we can deal with suctioning. The emergence reaction usually doesn't happen with IM so much because it kind of wears off a little bit more gently. But an agitated person that you give IV ketamine to, as it wears off, as their brain reconnects, can have some pretty significant neuropsychiatric effects from it, which you can either resedate with some more ketamine or give some midazolam for at a dose of like 2.5 to 5. If that happens, probably best to talk to online medical control for about it. Laryngospasm, a very bothersome side effect of ketamine, where essentially the patient's larynx seizes up and they can't breathe through it. In order to break that, a lot of times there's this Larson's maneuver, which we can, if you reference my talk on ketamine, shows you how to do that exactly. But a lot of times we can bag the patient through it. Some firm positive pressure ventilation with a good seal will often pop the larynx back open. If need be, you can also give more medication, again, Versed, and be able to break that laryngospasm. Of note, this is for paramedics only. Giving benzodiazepines and ketamine for sedation or for relief of agitation are not in the advanced EMT scope of practice at the time of this writing or the time of this video. There is a quick reference table in the back of the protocol just to give you an idea on dosing. Again, ketamine is a pretty safe drug, and I lean on ketamine because folks are probably going to be interested in getting into it. Ketamine is a pretty safe drug as long as you recognize that once you give it and it does its magic, you have to be able to treat the complications of it, which we can. It's airway stuff. It's sometimes cardiac dysrhythmias and that sort of thing. We are able to treat those things. We probably won't get into it if we are providing good critical care for these patients to start off with. It probably won't happen to us, but we will be ready in case it does. And again, I can't say it enough. Good critical care for these critically sick patients will help protect you and help protect these patients. And that said, we will see you next time. Stay safe out there.